This conference will now be recorded.
So my dear friends, the best way to revise topic is by revising its question. Okay, so I will start by an exam scenario. So as you can see here in this scenario, you have a pregnant patient with Crohn's disease, and she had a flare with which controlled only by the hydrocortisone high dose. So the patient had a flares, okay, and difficult to control, only high dose of hydrocortisone. You know that the steroids are safe in pregnancy, but not in the high dose. Only the precautions with the use of the steroid that we will increase or give stress dose during labor, during delivery, and during the antenatal, we will check for the GTM as it increase the risk of diabetes. Otherwise, high dose is not recommended. So you consider using another drug. Okay, so this is a good decision to help reduce side effect of high dose of the steroid and the flare recurrence. Which medication to be used in this case? Okay, so in this case, we have the sulfasalazine, we have the methotrexate, we have the mycophenolate, and we have the tacrolimus. We have methotrexate and mycophenolate number C and D, and it should not be used in pregnancy. People can go to the sulfasalazine. No, this is not for the cases with recurrence and flares, okay, or the tacrolimus. So let's see here the choice from the table, okay, and this table comes from the TUC article directly, okay. So this table show you that the azathioprine, okay, this is the cyperine group. This is have no increased risk of preterm birth, low birth weight, and neonatal adverse outcome or congenital abnormality. Azathioprine is preferable as fetus cannot convert it to the other purines, less exposure to the active metabolites. Okay, so this is if we speak about a drug to replace the steroid, right? But how about using in a short-term flare? Meaning that you have a case now with flare. Will you go for the metronidazole for active flare at the moment during the pregnancy, or you will go to the azathioprine? Okay, so for the acute only, you will go for the metronidazole, and it's a short course. Okay, and this is for the perinatal, okay, Crohn's disease and initial treatment for flare. Okay, so I have a recurrent flare and I want to replace the high dose of steroid. So in this case, which one I will use? Yes, this is the azathioprine and it's considered safe. And if I have initial management of flare during prenatal period, I will go to that metronidazole. Okay, is it clear so far, guys? Okay, so what if you have a patient with ulcerative colitis and she have no medication and she got a flare with fever and bleeding, fulminant colitis? Now, if I have in the choices metronidazole for the fulminant colitis, okay, or I have tacrolimus, which one I will go for? I'll summarize, Dr. Sabah, for you. Okay, then I'll go back to the table and I'll find that the calcineurin inhibitors like the tacrolimus or the cyclosporin can be used, but its limit used to fulminant colitis and rescue therapy in steroid refractory ulcerative colitis. Okay, so I have different scenarios here. Prenatal, preconception, I want to replace the high dose of steroid. Which drug is helpful in this scenario for replacing high dose of steroid because the case has recurrence? This is the azathioprine, and it's immunomodulator, okay, and it's particularly beneficial in patients with IBD to prevent recurrence and steroid sparing agent, right? This is the azathioprine. Clear? Okay, so I have a case with Flair during pregnancy or perinatal period, and he's asking you initial management of this flare. Which drug can be used? Initial management of flare. Which drug can be used? This is the metronidazole. Yes. Okay. So I have fulminant colitis. Okay. Which one is for the fulminant colitis? Fulminant colitis, the question actually came in the exam, but previously there was a similar scenario in a strategy before this exam. So in the strategy question, because the question was complete, the patient had received the steroid and no effect during the fulminant colitis attack. So it's the tacrolimus in this case. Yes, excellent. So what are the precautions to use tacrolimus, guys, in pregnancy? If a patient hair condition need the tacrolimus for control. So if there is any risk associated with the tacrolimus or the cyclosporin in pregnancy, like yes, GDM, excellent, Dr. Sabah. So yeah, so they are associated with increased risk of GDM. Anything else? There is concern about the toxicity. Okay, so the patient with long use of the tacrolimus in pregnancy, they need their dose to be monitored. Okay, anyway, just I want you now to know the recent question that appear in the exam, and it's likely that you find it in September or find similar scenario to it, so please take care. Other classic question comes from this table is about the drug side effects. Okay, so let's go drug by drug here. So the aminosalicylates, like the sulfasalazine or the mesalazine, okay, both are possible to be used during the pregnancy and does not significantly increase the rate of miscarriage, birth defect, low birth weight, stillbirth, or preterm delivery. But we will avoid doses greater than 3 grams per day because of the risk of fetal nephrotoxicity. Okay, guys, so fetal nephrotoxicity associated with which dose? Is it a general side effect? No, it's only for the doses more than 3 grams per day. Excellent. So fetal nephrotoxicity associated with high dose only for 3 grams. High dose folic acid supplementation will be recommended if the woman use sulfasalazine, of course. Okay, so which drug is associated with bloody diarrhea in the infant, in the newborn? The bloody diarrhea associated with the mesalazine. Okay, so yeah, the drug side effects are very important. Sulfasalazine is associated with only nephrotoxicity when it is used in high dose, more than 3 grams per day. Mesalazine, please be careful because it can be associated with blood diarrhea in the newborn. Okay, 2 questions from the recalls and repeated questions, so we have to be careful because it comes in the detail, very detail of the TUG article. Then what other question that we need to review here? So we have the metronidazole, okay, and we said what is the use of the metronidazole? Short term only, okay, for the cases or the initial management of flare of Crohn's disease in pregnancy or perinatal. Steroid, we all know about the steroid. Yes, we can use it, but the precaution with the steroid use is very important. Of course, it can achieve a rapid disease remission, increase association with maternal hypotension, gestational hypertension, gestational diabetes, small for gestational age, preterm rupture of membrane, and preterm delivery. It can cause neonatal adrenal suppression at higher doses. That's why we'd like to avoid it in higher doses and replace it with the azathioprine. Prednisolone, hydrocortisone, preferred as rapidly metabolized by the placental enzyme, lower fetal exposure. There is limited data, okay, in the Budin side, okay, use, and we give stress dose at the delivery. So who is very smart and clever and will remind me with the stress dose at delivery? Yes, so it's 50 to 100 every 8 hours. Yes, and we use the hydrocortisone. Yes, excellent. Okay, so the precautions with use azathioprine, as we said, azathioprine is a risky drug, but it can be used only in some cases, okay, and is not associated with preterm or low birth or neonatal adverse outcome or congenital abnormality. So we use the azathioprine from this family for the cases of high dose steroid is not effective and they have a recurrent flare. So to prevent more in the pregnancy, in the preconception, we can use the azathioprine. The tacrolimus has a limit use only for fulminant colitis, and please do differentiate between flare and fulminant colitis, okay? So a fulminant colitis, which is a life-threatening condition, and rescue therapy in steroid refractory ulcerative colitis. So there is steroid refractory means steroid is used but not effective, okay? Is not able to control the flare, okay? So in this case, we will replace with the tacrolimus. There is possible association with low birth weight and preterm birth with the tacrolimus. How about the biologic agent? The biologic agent like the infliximab, okay, for example, it can be used, but very important, okay, that you will remember the table from the TUG article of biologic agent is about when to stop, okay? Yeah, but the exact date for every member is important, and this table we will come to it, okay? So that's very important. The microfinolate also is a site of exam question, but this drug is not used in pregnancy. The advice is to stop it 3 months before conception and start on high dose folic acid, right? How about the methotrexate, last drug in the table? The same thing, contraindicated to be used, and when we will use it, you will use it only no, not used. So stop at 3 months excellent, and give high dose folic acid for the woman before pregnancy. Whenever there is a woman with methotrexate, it's very important that we advise both men and women, because it's antifolate, right? So it affects the DNA. It will cause a problem in the DNA, and possibility of major congenital abnormality and disease in the newborn. Okay, so actually we will advise both male and female not to try for pregnancy unless stopped right before conception. Okay, so 1 second now. Just I would like to revise with you something from the article. Okay. Okay, so I think that the best way to find my TUC article rather than, searching on my computer, which is now loaded with files, is to go to the TUC article channels, okay, the MRCOG TUC article channel, and find whatever TUC article I'm looking for, right? And you will find a very concise summaries, guys. I would advise you that you follow this channel, okay? So, okay, so from this TUC article file, okay, we'll find here, yes. Okay, so let's see the problems associated with the biologic agent and their use. Okay, so this is again important for your exam. So the infliximab, what is the mode of action of the infliximab? It's anti-tumor necrotizing factor agent, right? Yes, okay. So when to use it? We use it in the cases of autoimmune problems, like for example, the rheumatoid arthritis, right? Okay, so then how about the anti-interleukin 1? It's the same thing, but it's provide competitive inhibition of the interleukin 1 by binding to any interleukin 1 receptor in a wide variety of tissue. Okay, so what is the common indication? Neonatal onset multi-system inflammatory disorder and rheumatoid arthritis. Okay, that's why it came in the article of the rheumatoid and arthritis. The anti-interleukin 6, okay, so it's again used in the rheumatoid arthritis that's refractory to the anti-tumor necrotizing factor agent. So if you have a case refractory to infliximab, so anti-interleukin 6 can be helpful. Okay, so there is T cell stimulator or inhibitor. Okay, those are a cytotoxic T lymphocyte associated, and they are used in the severe rheumatoid arthritis. Okay, and despite conventional disease modifying and anti-rheumatic drugs. B cell depleting agent, okay, like the rituximab, for example. So it is monoclonal antibody against the protein CD20. This can be used in non-Hodgkin lymphoma and chronic lymphocytic leukemia, and it can be used also in rheumatoid arthritis or immune thrombocytopenic purpura. Can be used, okay, the belimumab. This is inhibit the B cell activator factor, and this can be used in the systemic lupus erythematosus. In exam, does they ask about what are the uses? No, they don't ask about what are the uses, but they will ask about when to stop it. Okay, so the when to stop it table is the golden table for your exam. How about the etanercept? Its half-life is 4 days, so it can be cleared or washed out from the body in 4 days. Good. Cord blood to maternal serum concentration is 3.6 to 7.4. So that's mean, okay, effect on fetus is less. So that's why you will find that we stop it at 30 to 32 weeks. Okay, so that's, please remember the etanercept, the first one, 32, 32. Infliximab. The infliximab is the question of the recall, but you know, as they like one topic, you can find another question around the same topic. Okay, so maybe they will bring this time another agent from the biologic agent. The infliximab stay higher, stay for 10, the half-life is 10 days, and the cord blood to maternal sample concentration is very high, up to 400, so we stop it early. So this one, the earlier one to stop, and it's at 21 to 22 weeks. The adalimumab, okay, this is again 10 to 20 days half-life, and it can reach up to 300 in the cord blood to maternal serum concentration, and we stop it at the 26 to 28 week. How about this drug, the certolizumab? This drug, okay, can be used throughout the pregnancy. That's why it has a star here, okay? So it's safe to continue throughout pregnancy. However, suggested gestation to discontinue at 28 to 32 weeks. Okay, so this is actually comes from the Nelson Percy, Catherine Nelson Percy book. Okay, and believe me, whatever took article written by Dr. Catherine Nelson Percy is important for your exam. Okay, that's why the maternal medicine took articles are important. Okay, so please take care of this table very much and take care of the question that can come there, and hopefully that this table will be easy to memorize in your exam. Guys, any question here in this part of the inflammatory bowel disease? I hope it's easy. Okay. Not easy? Okay. Okay. So guys, one by one. Okay. The question number one from Dr. Raida, she's asking about the metronidazole can be given other than the perianal. It can be used according to the table. It can be used as a short course for the perianal Crohn's disease and the initial treatment of Flair, right? Right? So there is two uses, yes. It can be used for the initial management as a short term, or it can be used, okay? Okay. So dear, yeah, the question of, yeah, the question of the male. Yes, yes, Dr. Soma, it's used. Okay, so your question, Dr. Sabah, is about the male, when to stop it. So what do you think, when to stop it? Because I know that there is two evidence are there, okay, is about to stop it 3 months before the conception or to stop it 6 months before conception. So which one you will use? Okay, so recently, Dr. Sabah, there has been advice from the BNF, okay, that it now is it's like clear to be stopped in both male and female 3 months before conception. Okay, and the BNF, if you don't know about it, it's the British National Formula. Okay, clear, guys, so far? Okay, I hope it is. Okay, so let's see. Yeah, so let's see one important topic with one question, okay, that came recently, and I think that you can find more from the peripartum cardiomyopathy. Okay, so before we go to the peripartum cardiomyopathy, I would just like to remind you that what is the most common cause of indirect maternal death? This is the cardiac disease. Excellent. Okay. So among the cardiac disease, what is the most common cause of cardiac problem that lead to death? Okay. So the cardiomyopathy is one of the recent causes and it's very high. Okay. However, okay, the entity of ischemic heart disease, okay, yeah, the entity of the ischemic heart disease is much higher than this. Okay, so yes, I know that cardiomyopathy comes as now one of the trends or the highest, okay, but rhythm problem. Okay, so actually, yeah, now guys, you have told me all the problems, okay, or you have told me or the problems with the cardiac disease, all the disease in cardiac. But my dear friends, okay, when the question comes in the exam, yeah, the ischemic heart disease is higher all over. Okay, this is from the maternal morbidity and mortality report, okay, regarding which one is higher. So you can see here, hopefully that you can see my screen. Okay, so this is from the key message from the report. In the recent report, we are still with the same. Okay, and I remember that the question when it came in the exam, it was a 2021 question asking you about the recent causes. Okay, so heart disease, 23% of all the disease, and from the ischemic heart disease, okay, and we find is that it's alone, it's by itself, it's 22%. Okay, so it's alone by itself, this entity is 22%. Okay, okay, so 1 second. Yeah, if you have a single disease, a single condition, Okay, so because MI is under the ischemic heart disease. Okay, so if you have a single condition or a single disease and you are to choose between the MI or the cardiomyopathy, so which one you will go for? You will go for the MI, definitely, yes. Okay, yes, cardiomyopathy is very important. Yes, it's a very important, and it's because there is a recent article, so it's a trending topic for the exam. But however, guys, the problem with the cardiac disease, it's the acquired cardiac disease. We are facing the problem because of the lifestyle, because of the obesity, okay? So smoking. So that's why we have the problem with the acquired disease. So please take care, okay? Because I know there is some confusion because as I told you before, any introduction of a book article, they will tell you that this particular condition is one of the most common causes of cardiac or maternal death in pregnancy, okay? So let's see here in the cardiac disease in pregnancy why it's very important in your exam, simply because it has 23% of the causes of death due to cardiac condition. Okay, so this is the why it's important. Still, they decided, okay, to remind you of the effect of pregnancy on the heart, and they bring it as a single best answer question. So cardiac output increased in 30 to 50% in pregnancy. Heart rate is 10 beats. Stroke volume increased. Plasma level is increased. Preload increased. The only parameter that decreased is the vascular resistance. The ejection fraction likely to be during normal pregnancy is 60%. Ecg changes during pregnancy also is important when it's considered physiological, not pathological. So when you have atrial and ventricular ectopics, when you have left shift in the QRS axis, when you have a small Q wave and inverted T wave in let 3. ST segment depression and T wave inversion in the inferior and lateral leads. This is the classification of the heart disease, like NAHA class 1, 2, 3, 4, as you know. So it comes from the mild to the most severe. We know that when we have a patient with the NAHA class 1, so it's likelihood that the pregnancy will go without complication. NAHA class 4 is the contraindication to be pregnant, actually. However, if she wants to be pregnant and continue with the pregnancy, then we need to advise elective cesarean section for her. For the NAHA class 3, advise also for elective cesarean section, but if she wants to have a vaginal delivery, then in this case we will use instrumental delivery as prophylaxis for prolonged pushing and prolonged second stage. Right, guys? Okay, so let's come to a simple introduction to the peripartum cardiomyopathy. You know, guys, that the peripartum cardiomyopathy, we have two conditions associated with cardiomyopathy. One is the hereditary type and one is a non-hereditary. We tend to find that the hereditary type, which is autosomal dominant condition, is not associated with higher risk of the pregnant woman of death. But the problem comes with the peripartum cardiomyopathy. And the peripartum cardiomyopathy, peri means it's around delivery, right? So it can come in the third trimester, it can come in the
postnatal period.
yes, excellent, and up to 6 months of delivery. So the patient, when she had a peripartum cardiomyopathy, what is her risk factor? Risk factors to have this condition is like general risk factor, like age, being old age mother, like she had a hypertension in pregnancy, like black ethnicity. Okay, so those are the things that make us think that multivirus also make us think that this woman would be at higher risk of this condition. Okay, so how this condition present? This condition, when it presents the peripartum cardiomyopathy, it presents with cardiac failure, heart failure. Okay, so simply Okay, the patient will have breathlessness, she will have tachycardia, she will have gross edema, she will have supraventricular tachycardia as well. So the first investigation, initial investigation, if you have a patient with breathlessness, tachycardia, gross edema, and supraventricular tachycardia, what it will be? Yes, Dr. Omaisa, excellent. So cough will be there. What will be the initial investigation? Excellent. This is the ECG. Initial investigation is the ECG. However, those are red flag signs. Red flag signs of heart failure in pregnancy. Okay, so this should prompt a cardiac opinion. You need the cardiologist to come, and it also prompt echocardiograph, right? Especially if this patient had a previous history of peripartum cardiomyopathy in the previous pregnancy. So that's mean she's at higher risk of recurrence. Okay, so red flag signs in any patient presented with breathlessness, tachycardia, gross edema, or supraventricular tachycardia, please remember she will need, in addition to the ECG, an echocardiograph. What you will find in the echo? ECG can show you the tachycardia, can show you the supraventricular tachycardia, but what you will see in the echo, guys? Echo assesses the function of the heart. So what is the value that we're looking for in echo? The ejection fraction. Excellent, Dr. Aya. So the ejection fraction and the left ventricular dysfunction, as you said, Dr. Salma, excellent, should be reduced. Okay, so ejection fraction less than 45, what you will call it? Yes, dilatation, thickness as well, because it's like, yeah, you will see that there is dilatation of the ventricle. Okay, that's why it's called cardiomyopathy, right? Excellent, excellent, everyone. Okay, so I see ejection fraction less than 45. I see the abnormality in the heart rate, like the supraventricular tachycardia, for example, okay, by the echocardiograph. So now I have the diagnosis of the peripartum cardiomyopathy, right? Okay, so what should I do now? What is the management if I have a case of peripartum cardiomyopathy? Like the case that came in the exam, simply the patient presented with those red flag signs, and by the echo, they have found that there is left ventricular dysfunction. Yes, okay, so yeah, MDT management. But if they ask about drug management, which drug shall we suggest? Okay, so first of all, let's see the table. Let's see what in the algorithm. This is the checklist for the management of acute heart failure caused by the peripartum cardiomyopathy. This was your exam question in July 2022. Okay, so MDT approach to manage women with peripartum cardiomyopathy, avoidance of heart failure drug with teratogenic risk during pregnancy and breastfeeding, like the ACE inhibitor, like the anti-ARPs, and the mineralocorticoid receptor antagonist. Consider bromocriptine, okay, 2.5 mg twice daily for 2 weeks, followed by 2.5 mg per day for 6 weeks. Anticoagulant with low molecular weight heparin, especially in women with left ventricular ejection fraction less than 35 or equal to 35. Okay, so if the patient had bromocriptine treatment or she had left ventricular ejection fraction 35 or less, so what you will give? Low molecular weight heparin for this patient. If the patient had shock, which is very important, so you have a patient collapsed, she had cardiogenic shock, okay, and resuscitation had been done for her, started resuscitation. Which drug to be used? So a patient with heart failure, left ventricular dysfunction, she had shock. So which drug to be used? This is the levosimendan. Okay, so the levosimendan, excellent, Dr. Sabah. This is the drug of choice. What is the route? This is infusion. What is the rate? 0.1 microgram per kg per minute for how many hours? For how many hours? For 24 hours. This is instead of the catecholamine and first line inotropic drug. If I have in the exam, and this is what happened, 2 cases. One case, she got collapse, okay, because of anaphylaxis. So her heart stopped. I want to give her inotropic drug. Which drug I will give? This is anaphylaxis. She doesn't have any underlying problem. Management of anaphylaxis, guys. Okay, so you give the adrenaline. Excellent. Okay, so you give the adrenaline for the patient of anaphylaxis, right? Excellent. What if you have a patient collapsed in the same question, in the same MQ, but this patient, she had history of left ventricular dysfunction and heart failure. Now, can I use adrenaline for this patient, for resuscitation of this patient? A big no. Yes. So what is the drug of choice for a patient with left ventricular dysfunction? Is the levosimendan. Okay, guys. Simple. Yes. Okay. So the drug also dose and route, please take care of it. So it's 0.1 microgram per kg per minute for 24 hours. Clear, my friends? So this is early transfer to specialist care center with evaluation of mechanical circulatory support when necessary. Dr. Raida, I can see 2 question marks. This one is rate, so it's infusion. The levosimendan is infusion there. Okay, so let's see the algorithm. You might have a question in the diagnosis. Okay, so you have a patient presented with shortness of breath towards the end of pregnancy or postpartum period. Okay, what are the initial investigation? Forget about the algorithm now. What is the first investigation? Shortness of breath. ECG, excellent, and X-ray, of course. So first things are first. Those are the ABCs of management. Yes, okay. So the patient has chest pain. Would you like to request troponin T for her? Okay, so it's normal. You think by the clinical management that this is a case of heart failure. Okay, so what are the specific investigation if you suspect a peripartum cardiomyopathy or heart failure in the perinatal time? Yes, now we will ask for the natriuretic peptide, the BNP or the NT, pro-BNP, and echo cardiology. Okay, so if you have high clinical suspicion that this is a peripartum cardiomyopathy, because I don't want you guys in the exam to miss a case. For example, you have a case presented with, sometimes Okay, sometimes we'll be like overcautious for some topic. Dr. Rabah, she had revised in the last week before exam the cardiomyopathy, so I have seen in the exam comes with shortness of breath, chest pain, and I will run to the BNP, the natriuretic peptide, right? Why? Because I've just revised this table. No, please, basic things comes first. If you have in the scenario, don't forget that you have pulmonary embolism in this curriculum. Don't forget that you have MI in this curriculum. So look to the clinical picture very well before you choose. So the clinical picture suggestive of peripartum cardiomyopathy, what you will do. If it is suggestive of cardiomyopathy, then you put the answer of a specific investigation for cardiac failure, which is the natriuretic peptides, the PMP, okay, or the NT-proBNP, and echocardiology, okay? So I will see where the question will take me. Is it shortness of breath plus tachycardia? Start with ECG, okay, because you don't know which, scenario is it. Is it, no, this is heart problem or history of heart problem. She's a smoker, she's obese, she has a central pain or to the left side and radiating to the left arm or to the jaw. Then I think it's MI. So if I have the clinical picture specific for certain condition, please choose the specific investigation. If initial, go to the ECG, okay? So clear, guys? So Dr. Banu dear, I will request the investigation according to the clinical scenario, okay? I will be very careful with the word initial investigation or initial management. Usually initial management means that you will take step in the resuscitation of this patient or stabilizing this patient. Initial treatment that you will put a drug or can be oxygen for some cases. Initial investigation means that you will ask for a specific test, right? The most helpful test at the beginning. So please careful with which scenario you have. What is the leading word in the scenario, okay? So I have a leading word in the scenario saying that the patient presented to me with gross edema and with tachycardia, with shortness of breath and cough, okay? So I have started with the ECG for this patient, okay? Then he added one word or he added something that you are suspecting peripartum cardiomyopathy. What is the initial investigation or what is the investigation of a choice? So here I will go for the specific investigation for the cardiomyopathy, natriuretic peptide, and the echocardiology. What should I expect to confirm my suspected diagnosis? I would expect raised natriuretic peptide more than 100 pg per ml, or if they use the NT-proBNP, this will be more than 300. So guys, remember, yes, the cutoff. And the ejection fraction is 45 or less. What was the normal again during the pregnancy? The normal, yes, 60, excellent. So we have the 60, excellent. Now, the cutoff for the diagnosis of peripartum cardiomyopathy is 45 or less. Excellent. Okay, so once I have the ejection fraction 45 or less, plus the raised natriuretic peptide, I have now the confirmed diagnosis of peripartum cardiomyopathy. What is the management? Management means that you will look to the holistic approach. Okay, so involve the cardiology, consider the peripartum cardiomyopathy and the other cardiovascular differential diagnosis. Okay, if I have the ejection fraction more than 45 and the normal level of natriuretic peptide, so the peripartum cardiomyopathy is unlikely. Okay, guys. So this is regarding the algorithm in this stock article. Okay, the table of management is very, very, very important. I would like you to remember the MDT approach, avoidance of the teratogenic risk if the woman is pregnant, consider the bromocriptine twice daily for 2 weeks, okay, anticoagulation with low molecular weight heparin, especially if the woman had the ejection fraction 35 or less, or the woman is being treated with bromocriptine. The very important question in cases of emergency and cardiogenic shock, consideration of the levosimendan, and the dose is 0.1 microgram per kg per minute for 24 hours instead of catecholamine as first line inotropic drug. Is that clear so far, guys? Okay, so let's find some question from the July 2022. Okay, with regard to the management of the cardiac problem. Okay, so a pregnant with episode of supraventricular tachycardia. What is the preferred drug to terminate this episode and what is the route?
Unmute.
Okay, yeah, so yes, your answer is correct, guys. It is the correct answer. Pregnant with episode of supraventricular tachycardia. This is acute episode, so acute episode you need to terminate it. Okay, this is from the the arrhythmia in pregnancy. So IV adenosine is the answer, right? Yes, excellent, Dr. Salma. Okay. If I told you that you have a pregnant presented with episodes of supraventricular tachycardia, and currently she's stable, she's in your clinic. If the patient is stable and you want to give her something to terminate episodes of tachycardia. Yes, Dr. Afroz, excellent. Okay, so it's the beta blocker, right? So for prevention of the supraventricular tachycardia, the patient presented with palpitation, increase of her heart rate. This comes on periodics, okay, last for 5 minutes or more. Okay, so yeah, so this is for the prevention. For the prevention, guys, yes, she will need a cardiology opinion, of course, but for the prevention is Dr. Maisa, she will follow up with the cardiologist, okay, not with us, but for your knowledge, because you are the obstetrician and you know that every other specialty will come back to you and ask you, is this drug safe in pregnancy, right? Even the dentist, before he infiltrate local anesthesia, he will come and ask you, is that safe in pregnancy, right? So whenever we have a pregnant woman, our colleague comes for opinion to us, so we need to be aware. This is all about it. Actually, in real life, we are not dealing with cardiac failure, or we're not dealing with adenosine. We are not dealing with any cardiac emergencies in real life, right? But yeah, yes, dear. Okay, so are beta blockers safe to use in the pregnancy? What do you think? Yes, sure. Okay, so as a prophylaxis for future episodes, we can give the woman beta blocker. Okay, so as a prophylaxis, beta blocker can work in acute condition like the case in the exam. Then this is emergency, and in emergency, we will use the adenosine IV to terminate the episode of the supraventricular tachycardia. Okay. Yeah, and you will find in the same file some information about the adenosine administration if you are interested. Okay, so this again comes from the TUC article about the use of the arrhythmias and its drug. Okay, so we are concerned about the safety of the medication. So the adenosine benefit outweigh the risk of fetal toxicity in large doses, and it's considered safe in breastfeeding as well. Again, this indication is for the acute episodes of the supraventricular tachycardia. There is amiodarone, and this is suitable for short-term use in emergencies. Okay, prolonged use is associated with fetal thyroid abnormality, growth restriction, and prematurity. Risk might outweigh the benefit. There is risk of neonatal hypothyroidism. Beta blocker, commonly used in pregnancy, yes, so it can be used. Benefit generally outweigh the risk. It's considered safe, and it's used in the prophylaxis, not in acute management. Okay, so guys, make sure that your mics are muted. Thank you. Digoxin, okay, can be used. What is the indication of use of digoxin? Digitalis. What's the indication? It's used only in cases of cardiac failure, right? And it is safe to be used. Okay, so the drug which is called flecainide, okay, this is likely safe. There is insufficient data to suggest any fetal issue. Also used to treat fetal supraventricular tachycardia. So this is for the mom or for the baby? This is for the baby, okay, for the fetal supraventricular tachycardia. Okay, and it's present in the breast milk, not known to be harmful. Lidocaine, okay, this can be used in resuscitation, okay, however, this is not part of your, required for your exam. Okay, so guys, this is a summary of the drug use and its safety. Okay, you will be asked also in the exam about some other medication. Like for example, you have a patient presented with collapse because of anaphylactic shock. So what is the preferred drug to terminate the episode and the route? Okay, so this is the adrenaline, okay? Yeah, and the dose that will be the 0.5 in 1,000. Please refer to the maternal collapse. IM adrenaline is more safe than IV, okay, adrenaline. However, you are bounded by the dose, okay? If you have both in them in the exam, please take care of it, okay? Okay, so yes, Dr. Rawa, this is the correct. Dr. Afroz, she's asking about the use of the amiodarone. Okay, so this is suitable for short-term use in emergencies. However, please take care that we will avoid the prolonged use and its adverse effect on the neonatal hypothyroidism. Okay. Okay. Okay, guys. So I hope that I have answered the tricky questions that you have asked about from the topics of the IBD, autoimmune, and cardiac. Okay. We have a small or a mini mock for cardiac problems, okay, which I will ask our dear Dr. Nada to post it to the group. Okay, so good luck in solving this mini mock, guys. It has very important questions for you. Thank you. Good luck in your exam, and we will have similar sessions of like this. Please post the topics that most confuse you, and I will arrange the session before your exam during this week. Thank you very much.